The first talk will be by Professor CHINTAN Malhotra. She is a professor at PGI. She is doing great work in cornea, cataract, and refractive surgery for last more than 15 years, and she will help us making us understand the basics of eye trace machine so that we can then build upon that how to use that information in improving the outcome of various aspheric, monofocal, EDOF, multifocal, and toric IOLs. Dr. Chintan.
Thank you very much, sir, and a very good morning to all present. So my talk, as Professor Jain mentioned, is about ray tracing aberrometry with the eye trace. I'll be sticking to the real basics. This talk is basically for somebody who is not really familiar with what an eye trace is, and so it help. And I hope that it will help to understand the concepts of what we are looking for, and then the subsequent speakers will be talking about each of the functions of the eye trace. So the eye trace is basically a 5-in-1 technology. It is a wavefront aberrometer. So it measures the wavefront coming out of the eye to measure what are the imperfections in our eye. It is incorporated or combined with a placido-based corneal topographer, which measures the aberrations from the cornea and also tells us about the topography of the cornea. It also has an auto refractor, and the advantage of this is that it gives us multi-zone refraction in different zones like 4 pupil, 6 pupil. So that helps us to know what the refraction the patient has in mesopic conditions vis-a-vis scotopic conditions. It is an autokeratometer, and of course, it is a pupillometer. So the principle of ray tracing is that it uses near infrared beam of laser beams, and 64 beams are projected sequentially 4 times at different locations on the retina. So what I mean by sequential is that one laser beam goes, then the other goes, then the other goes. They are not projected simultaneously. And since they are projected 4 times, so we have 256 points which are mapped. The advantage of this sequential projection is that in highly aberrated eyes, for example, in keratoconic eyes or irregular corneas, the data confusion is minimized. And that's why it is able to capture reliable data despite there being a lot of noise in the data per se. So the beam pattern can be scaled to pass through variably sized pupils. It can be scaled to pass, and that does it automatically through a 2 pupil vis-a-vis an 8 pupil also. And so that again tells us about how the eye is behaving in different conditions. The retinal positions of all these rays that are going into the eye are mapped to form a retinal spot diagram, which is seen at this bottom. This is a retinal spot diagram. And the rays which come back from this, that is known as the emergent wavefront. That is what is actually mapped as the ocular wavefront. And the deviation of the emergent wavefront. So we have mapped what is going in. We already know what is going in and where it landed. And then we measure that whatever was coming out, how much is it has it shifted from what was originally sent in, or how pure or impure are the quality of our vision is. And that's how we get the ocular aberrations. Now, before we go on to this, because it shows a lot of data points, we have to check the reliability of the data acquired. And for that, before we see anything, we should see the wavefront verification display, because it helps to verify the integrity of the data. For this, we look at the top left-hand screen where one can see that yellow circle. If more than 10 points are shown as rejected, it states that the reliability is questionable and the map should be acquired again. The lesser the number of points rejected, for example, you see these clean peaks, and this is obviously a very good retinal data, and this is a minimally aberrated eye. We all know that the eye has imperfections, so it can never be a complete circle. A circle is projected in, but we will never get a circle out. Sorry. So, in an eye with minimal aberrations, all 256 spots should fall on the retina, and the retinal spot diagram should be a closely packed cluster, a perfect circle. But, like I mentioned, we already know that the human eye is really perfect. So, even this map at the bottom is a good spot diagram. It shows an eye with minimal aberrations. The point is that the retinal spot diagram should not have large areas of discontinuity. Then we see this map on the right of your screen. Now, this is zigzag, but this is not unreliable data. It is just because we see the verification displays again showing that just 1 point was rejected. So this just shows us that the optics of the eye is not good, not that the data is not reliable. So that's the importance of looking at the verification display. Now, what does the eye trace actually measure? So it measures the total imperfections of the eye, that is your total aberrations. The corneal data we get from the placido-based topography. The wavefront we map from the laser, infrared laser beams which are going in. And then the internal aberrations we get from the total, that is the total wavefront minus the corneal. And the internal are usually attributed to disorders of the lens, although they can come from the other structures as well, but mainly it is the internal aberrations could be used interchangeably with the term for the lens. So the ability to separate these lenticular from the corneal aberrations is what makes this technology basically unique, and how the other speakers will be building on it, how we can use it to our and to the patient's advantage. Now, this is the basic display, the Chang analysis, which was given by Dr. Chang, and which is why the name the Chang analysis, and gives us a lot of information. Looks confusing at first, but if you look at it component wise, it's fairly simple. So we have this top right, we have top left, sorry, we have it's showing there the internal, which means that this is showing us the internal aberrations, the lenticular aberrations. So we should start from this actually. We have the total eye aberrations, the different aberrations are given here. I will not go into that. Then you have the internal, which are actually got by subtracting these corneal aberrations from the total eye aberrations. So that means you get the lenticular, you get the corneal. These are separated in this vertical column here. And the red and the blue are opposites. So one from the cornea, usually one will see that something from the cornea in a good eye with good optics, one will cancel out the other so that an eye has minimal aberrations. So that's the corneal aberration. Then we have the axial map at the bottom, which is showing us the topography. And on the sides, we have this zone, which is showing us the refraction. It is showing us what I mentioned, the multi-zone refraction. So you have refractions at different areas. This map is also telling us that this was measured in a maximum pupil diameter of 5.7 millimeters. That's where the data was acquired from. And this sign here means that this is done with spherical correction only, which automatically is being put in, but not with cylindrical correction. If we see this, if this red bar is not here, this red bar, that will mean that we've been doing it with spherical and cylindrical correction. And if we, so that probably we'll see in some of the scans. And I'll come to the other parts of the map later. So, for example, this is a patient being planned for cataract surgery, and we want to decide whether this patient is fit for a toric IOL or not. And if we look at the two boxes outlined in yellow, we see that the corneal aberrations and the total eye aberrations are mirror images of each other. What it means once we have mirror images of each other is that the main source of the aberrations is from the cornea, and we are looking at it that the astigmatism is the main aberration which is there, and the lenticular aberrations are there, but it's minimal. So this is a good patient for a toric IOL. The other advantage that it provides us is that we can, once we have torics and we don't have, this is a post-op thing, if we don't, we want to see what the post-op result is. Suppose the still patient still has a residual cylinder, so this will tell us how much it's off and how much rotating it will help us. So like this is showing us that your corneal and your lenticular wavefront, so this is your intraocular lens in place now, this is our axis of the intraocular lens, this is your corneal thing, so we have to match that. And it's showing us that a 25-degree clockwise rotation will give us a significant change in the cylindrical power. On the other hand, in another example, this is showing that it's a minimal change and there is nothing which is required to be done. So that's a simple way to look at it. Then this is an example which is exactly the opposite situation of what I showed earlier. The yellow bars, the yellow diagram is showing that the total eye and the internal aberrations are exactly mirror images of each other. The cornea is fairly clean, which means that the main source of aberrations is from the lens. And if we look at it, the pathology is predominantly lenticular, like I mentioned. And on slit lamp, I've gone back reverse. Obviously, we would see the patient clinically first, but I've gone back. And on clinical examination, this patient had a very obvious lenticonus, anterior lenticonus, and which is why these aberrations were there. And so we know that the source of aberrations is the lens. If we remove the lens, the aberrations will reduce. So this patient underwent a phacoemulsification, and in fact, he was implanted with a symphony lens, because you're confident that the lenticular aberrations you're going to take care of and the cornea is clear. And this is around 4-5 years ago, and the patient had a 6/6 visual acuity on day 7 with a minimal cylinder. And we see now again that the internal aberrations have become zero. They have become so minimal from what the bars were there, and the corneal aberrations are what they were. So because of the removal of the abnormal crystalline lens, the aberrations have become zero. And this again is the visual, how the patient sees. This is a simulated version. This is an excellent display of how the patient can be taught about what their problem is, and for us all to see. So the upper column is the pre-op, the later column is the post-op. It shows us that pre-op, again, the quality of vision was this. That was mainly because of the lens. And now this is the post-op quality of vision, because the quality of vision of your lens, the intraocular lens, has improved. The corneal aberrations don't show much change, not too much change. So that's how it helps us to understand. Just the last couple of slides from my presentation, it has a lot of other data which we can use. So these value of the atlas rings is a data point to be fed in for the ASCRS calculator while we are using in eyes in post-refractive surgery. That's helpful. We have the effective refractive power, that again is useful in deciding the IOL power in cases with post-refractive surgery. We have the corneal spherical aberrations more than zero point 0.3. I'm sure it will be touched upon later. So if the cornea is highly aberrated, we do not want to put in premium multifocal IOLs, because then the patient will not have good quality of vision. And the machine itself in different maps also gives you those checks. It will show it in red or yellow, right? And the last is the angle alpha and kappa, which maybe just quickly I'll say. This angle alpha kappa is the distance between the visual axis and the pupillary axis, which is this. Sorry, this is the angle kappa between the pupillary and the visual axis, and angle alpha is the distance between the visual axis and the optical axis. This will be coming in later talks, but it's just that the angle alpha basically tells us the center of the bag, and it tells us where your IOL will center. So if your IOL is too much away from the from the visual axis, then the patient will not have good vision. And so if the angle alpha is more than 0.5 mm, premium IOLs are to be avoided. This is going to be covered in subsequent talks as well, so I've just done that. So just to conclude, an eye trace is basically a technology which we cannot do without if we have to do premium surgeries, premium implant, premium IOLs, as well as in understanding what are the reasons for the patient's other corneal pathologies, and also in analyzing our post-op results.